recording. And welcome everybody who's on today's call. And Marquetta, it's all yours now.
Well, thank you. Thank you. I am trying to get my show started here. Sorry about that. Good afternoon, everyone. As we are winding down into the last few dregs of the LNet core curriculum, today's subject is loss, grief, and bereavement. I will go ahead and get started with the presentation, but a couple of things I just wanted to make note of first before we go any further. And of course, that is the fact that actually today, Kathleen Supanio, I know you guys remember her from earlier on. I do have a resource from her, a document that she co-authored that I'd like to share with the group today. Also, please keep in mind that you guys can now sign on with lmhpco.org. This is your username is your password. Your username is your email address and your password is pass1234 ! And that will give you access to all of the materials that we have been covering during this session. Here is a glimpse of the page that actually shows the videos and all of the training materials, corrections training materials. You'll see here in the more in this section, that drop down will actually give you access to every teaching element that we have been able to provide during this course of training. And of course, like I said, after today, there will be 2 more sessions. The next session, of course, will be the final hours that will wrap up the LNet curriculum. And then the final session on June 3rd will be state minimum standards for hospice. And that's going to be taught by Ms. Ann Walker. In order to get your continuing education credit, of course, have to be able to follow through each of the sessions. The videos, of course, are just for references. They're not for the ability to receive credit. And then also at the end of the session today, I think Jamie will let you know when to sign in so that roll can be taken so that you guys can get credit for being on today. Jamie, did you want to add anything to this?
The only thing is within 24 hours, you should see an email in your inbox. You need to click on the inbox, answer the survey in order to collect your certificate of, today is 1.5 hours, right?
Yes.
Yeah.
Yes.
And then that certificate stays in your profile. So whenever you need to produce it, you can go in there, produce it, the certificate, and prove to your professional organization that you participated in that session.
Yes.
Thank you.
So today, looking at our objectives, a couple of things we'll talk about today. Of course, we'll look at loss and grief, bereavement and mourning. Well, not only will we define them, but we'll dig a little bit deeper and talk about the different types of grief. Look at some tasks and factors that are related to grief. Also, interventions that can be appropriate to help facilitate that normal grieving process. Be able to look at our own personal death awareness and cumulative loss, that definition and some strategies for dealing with that. Also identify some of the systems of support that we as professionals can access to assist in coping. That being said, I just want to say though, even though grieving eventually ends, a person never truly gets over the loss of a loved one. Grief process is triggered by many kinds of loss. We'll talk about that some today. And the more attached you are to someone, the harder that it is when you actually lose them. All right, as I look at the NCP guidelines, there are a couple of domains that I just want to make mention of today. The domain 7 is the care of that patient that's getting close to the end of life. And that's, of course, talking about approaching death with the patient, and even sometimes volunteers catch on those conversations, being able to identify the spiritual concerns that are related to the dying, death, and even those beliefs that are associated with death and afterlife. Being able to facilitate those cultural assessments and attending to any cultural aspects of care at the end of life. That includes those rituals and beliefs that people have as it relates to death and dying. Also supporting legacy building, whether it just be letting people tell their stories or reviewing their life. Funeral planning, of course, I know that that's a league all by itself in corrections. Just being able to be a part of that. Also being able to provide that grief and bereavement support. As I look at further looking at that process immediately after death, and that is the IDT, we're available to provide support during that overall that dying process. Looking at the psychological and psychiatric aspects, that's in domain 3 of this guideline. That is being able to support the patients and even the staff and volunteers that are could be experiencing compassion fatigue or moral distress. They could be experiencing grief, even loss and bereavement as well. Now, just looking at death at different angles, just want to ask, as human beings, if does any of this sound familiar? Got a single mother, only son was killed quickly in a motorcycle accident. That's a sudden death. Josh and Heather lost their 21-year-old daughter to suicide. Partner died of a heart attack. Spouse of 60 years died from complications of diabetes. That was like a long-term relationship that suffered. So, all of these are different types of losses, and people just actually grieve in different ways. So we all know that everyone experiences and have witnessed loss and grief. We've seen and we witnessed patients actually lose their health, their ability to thrive. A lot of patients experience some changes in their body because of being seriously sick or ill. We've experienced and we've witnessed patients die. Some die well and some have difficult deaths. So there are times when we can become kind of caught up in the conundrum of death and even begin to have some moral distress. So how would we even begin to process the grief? So everybody, like I said, identifies, they respond to, they deal with grief differently. And so that's something that we have to keep in mind, that everyone is not going to respond the same way that we do. People will not facilitate the grief process the way that we do. And we just have to keep those things in mind, not only as professionals as we deal with death and dying and as we care for patients, but then also just keeping our own values in check as well. Got a few definitions here. Of course, loss is the absence of an object or a position, ability, or an attribute. And that grief is that reaction to the loss. Bereavement happens, provides dispensation from usual activities for a length of time. I will tell you this, that according to state guidelines, the bereavement period is listed as 13 months after the death of an individual. And in the free world, what happens is the social worker or bereavement coordinator actually provide services via telephone cards, letters, just in remembrance of the death of the loved one, just to kind of provide support, and also can also refer out for counseling and things like that. Mourning, that refers to not the reaction to the loss, but just the process of putting that loss into place into everyday life. We also have to keep in mind that there are cultural aspects that have to be considered as we look at loss, grief, and bereavement. Patients, family, staff, everybody experiences losses. I think I mentioned that before, and that everyone grieves in their own way. From a standpoint of being a hospice professional, we just have to keep in mind that the interprofessional approach is the important way to do it. And that is just making sure that the nurses get everyone involved, the chaplains, the social workers, bereavement counselors, anyone that basically needs to be a part to facilitate that grief process. Of course, every single discipline can contribute their own unique expertise to that bereavement plan of care. So when we think about the inconvenience that happens when life is interrupted by serious illness, that patient's life, of course, is interrupted. Their family's life can be interrupted. Stability or the norm or schedules and routines can be disrupted. Isolation, of course, is magnified. And of course, just the hope Generalized hope can be interrupted as well. When we think about providers of care, those of us that provide care at the end of life, committed to prevent suffering. But a lot of times when patients are trying to find out the meaning of their illness, their suffering is usually creating one of the biggest challenges to getting to the bottom of that meaning. Here it says, is it that patients seek to find meaning in illness, or is it that they seek to find meaning in the life that is now left, in those relationships, and all that we value? Sometimes patients are viewed as being broken physically and spiritually. And this brokenness kind of allows them to get to that existential question that says, why? Even though they may not have the answer, it does sometimes be able to provide meaning for them to kind of seek the overall meaning of life. Of course, we as professionals have to respect the patient's suffering and their attempts to make sense of their illness as best as possible. Be able to allow opportunities for them to tell, to talk, to allow the patient to share their story. Also important that to be present and also be able to attend to the patients. From a serious illness standpoint, that impact on sexuality and intimacy. Now, I will say this, it's hardly ever assessed in the free world when you think about it. And I'm not really sure if anybody wants to weigh in on this, but it's not assessed with serious illness a lot of times. Lots of stages. Every stage has a different effect on their sexuality and their functioning. But a lot of times it's not even considered a part of the social, emotional, or even psychological coping, or even as a medical concern. But when you think about the overall, the life review, making meaning, that's kind of normal. And that kind of gets to that intimate side of a patient, because a lot of life reflection, from whatever standpoint a patient it has been in their life, they do a lot of life reflecting. A lot of times they have difficulty being able to cope with the changes that physically happen. And of course, this can make the suffering and even, cause them to be even more isolated. So, sometimes the questions is asked, has this illness affected them from an overall standpoint of being able to find themselves in intimate or being able to be close or have those type of situations where they feel free to share. I wanted to just share this clip, this actual slide. It's when you think about from the volunteer standpoint, those that are providing care to fellow inmates. I think that from a personal transformation standpoint, those inmates that help give that end of life care, they often say that they have a feeling or a sense of worth and purpose, which counteracts against those feelings of being worthless, that may have stemmed from whatever they have in their past actions or even from their experience in prison. Experience of caring for the dying can also foster compassion and growth. It can also allow for empathy, give them a greater understanding of the overall human condition, leading them to have their own personal growth experience and change. Providing care can also offer a sense of purpose and meaning to volunteers that provide care, particularly within that isolating environment, within the prison walls where inmates, oftentimes they feel disconnected from the outside world. Some inmates view end of life care as an opportunity for redemption and leaving a positive legacy on life, even as they face their own past issues and transgressions. Being able to closely interact, that interaction that is required at the end of life can lead to the transformation of meaningful relationships between those inmates, also can create a sense of community and support within the prison. There are a lot of benefits, of course, that can be provided, that can be allowed as inmates provide that end of life care, the volunteers, but it also can cause some challenges. That includes that emotional trauma and also the need for training that supports that inmate as caregivers. And of course, collaboration and advocacy, end of life care in prisons has to be, they have to be able to collaborate between the staff, other hospice organizations, and inmate caregivers. That requires advocacy for improved access to care and, of course, those resources for those dying inmates. There's a silent generation inside as well as outside of the prison walls, and that is, of course, the LGBT and the aging group of folks. I will tell you, this is a little 4-minute video. I've had difficulty with it connecting. I won't try to connect it to interfere with my connection on today, but it's just another opportunity for looking at those marginalized populations and how they cope with and deal with end of life and being able to provide end of life care. So when we look at,
But we'll put that video on the, we'll put all of the videos that we don't show on the
yes,
training.
yes, it will be on the training, the links for the training materials. Thank you, Jamie. So when we think about the patient's basic needs at the end of life, and this is universal. Everyone wants to be able to have as much control as they can over their own physical symptoms. They want to be able to have the feeling of getting provision of their needs. Also want to be able to have assistance and have dignity with elimination and their hygiene. Of course, their fluids and nourishment, companionship, or just someone to be there. And then also just being able to be recognized for their continued existence. You know, I think in recognizing these needs, I'd just like to share with you some important words that our actions promote the very best care. And it says, we will keep you warm. We will keep you dry. We'll keep you clean. We will help you with elimination, with your bowels and your bladder function. We'll always offer food and fluid. We'll be with you. We will bear witness to your pain and your sorrows, your disappointments and your triumphs. We will listen to the stories of your life, and we will remember the story of your passing. I'll move on into the next section that just kind of starts talking about the whole idea of the process of those survivors, those that influence the grief in the survivors. So some of the factors that influence the grief process, of course, that's the personalities of those that are the survivors. You have to think about from the standpoint of those volunteers that are providing care. Some seem to have the ability to compile death after death and maybe not seem to be phased. But then we have to be able to be alert and aware of the idea that everyone has to have an opportunity to grieve, has to have an opportunity to exhale, between deaths. And they also have to have an opportunity to look within themselves and realize that at some point in time, they may not die on hospice, but as we all live, every one of us are going to die. And of course, looking at their ability to be able to cope, whether or not they have a history of substance use, what their relationship was for the person that they cared for or that person that died. That, of course, would include the nature of the relationship, whether it was, conflicting or whether they were just from a standpoint of being an actual caregiver, could have had a history of being a cellmate or having had a close relationship at some point. Also thinking about the spiritual and the religious belief system of that person, the type of death, and of course that survivor ethnicity and culture. And then of course other factors are support systems and those concurrent stressors or the experience and history of losses that folks have experienced. When we think about fading away, as it's mentioned here, that's just that whole process of the changes that actually take place, realizing that the patient is no longer just living with a serious illness, they're also dying from it. And so when that realization comes to place, these are some of the transitions that actually take place. That redefining, that's kind of a shift for patients from what used to be to the way that it is now. So their whole life cycle has been changed, and this redefinition is now how they actually see themselves and the life that they have. Burdening, of course, when patients experience that lack of purpose, they become dependent. They kind of start to feel like they're a burden and don't want to be a burden on folks. So you'll see that even socially and spiritually. Of course, I've heard even, caregivers say, well, it's not a burden. It's my honor to be able to care for you. So, but these are some of the transitions that those people actually, patients will actually have. Also being able to struggle. They struggle with the fact that they're living and dying at the same time. They're living with that illness and they're also dying with it. So just struggling with that whole paradox of living and dying at the same time. Of course, contending with the change, the roles, the socialization, the patterns of care, not being able to no longer be able to care for themselves as well. And of course, also being able to search for the meaning I mentioned earlier. Um, People that are dying tend to want to journey within themselves to kind of get some spiritual reflection on life, or to become connected to um, people, even if it's not a physical connection, but just being able to connect within themselves to people that they may have disappointed, or people that have crossed their lives and they left in a not so good fashion, but just an opportunity to ask for forgiveness within themselves for that. And also just living day to day. Patients that find meaning, um, they typically are better equipped to live their last days with a positive attitude, as much can be expected. And of course, being able to prepare for death. Patients want to leave something behind, even if it's just something about their personality, something that they provided, something that they allowed, that they were able to leave, um, that legacy. So, what do caregivers want when they are grieving? Because, as I said earlier, caregivers could be anything from the staff, the nurses, the social workers, to those volunteers that are actually the hands on, a lot of times providing that one on one care to the patients. They want to know as much as that patient wanted, that those things are being honored. They also want to be included as much as possible. They want to be able to provide hands, want to be the hands and feet of the patient to provide any help. And of course, to be able to give some honest conversation. They want to be listened to. They want to be remembered as being able to provide good care, and that they have done all that they could possibly have done and provided for that patient. From a standpoint of a grief and bereavement, a program, that's a core component when we think about a palliative care program course. That involves that interprofessional team with all of the members of the IDT team. Also that ongoing reassessment, the assessment, and then the reassessment, support staff, taking a look at being able to look at the risks for some complicated grief, support and prompt referrals. Also, I mentioned earlier, like I said, on this side, there's bereavement services. I do know that, Jamie, was that like a couple of years ago where the grief support from inside was kind of implemented? Do you want to share just a little bit about that, Jamie, if you don't mind?
Well, 2 years ago, we started also offering training to the inmate population who wanted to be trained as bereavement facilitators, peer bereavement facilitators. And we trained about 36 people inside of Louisiana Corrections, and we're hoping that will make a difference. They are responsible for setting up their own support groups, and it's something that is extra correctional. It's something that we hope is going to be organic, and that the inmate that way no one has to document anything that's said in the support groups, and it's all led by uh, fellow inmates, people who are trained as hospice volunteers who went on for further training in terms of becoming a bereavement facilitator.
And as Jamie said, I think that that's in hopes of being able to provide those bereavement and also grief from a standpoint of they're shoulder to shoulder. They experience those things and they have an opportunity to kind of support each other as they have received training. So we're in hopes that that's going to be a great spin around that where that's something that could really benefit within corrections. Did
And
anybody have any?
yeah, as you know, the incarcerated can talk to the incarcerated in
Right,
a much different language than those of us who are not incarcerated. And the whole
right,
idea was to give them an equal platform to which to try to resolve grief issues, help them
right,
resolve those issues.
right. When we look at the grief process, of course, grief and loss or loss and growth actually happens, but um, distress is still present, could definitely still be present. There's those waves of normal and expected, the grief. There's opportunities where grief kind of prolongs and kind of pulls and kind of turns to depression. We have to also think about the idea of the cultural aspects because culture can also dictate how long a person mourns or how that survivor is supposed to act during that time of bereavement. Outward expressions of loss may be influenced by that personality, like I mentioned earlier, even the life experiences. And thinking about that spirituality, being able to assess that spirituality, of course, is also important because it can help with reconciliation. It can also help with self worth, being able to resolve guilt, forgiveness, or providing for forgiveness, or being able to even ask for forgiveness and setting right a relationship with God or even a higher being. Next, we're going to just start talking about a few different types of grief. Um, there are 5 types of grief here. The first one is the anticipatory grief, and that's defined as a grief before a loss. Of course, it's associated with the diagnosis or even whether it be acute or chronic or even terminal. When that patient first finds out, it's just being able to deal with actual or fear of potential loss of health or loss of independence when they start thinking about losing a body part or maybe even stability or even their choices. They start to have what is known as anticipatory grief. Acute grief that is the next one, and that actually begins right after the death, and it typically includes that separation response or that response immediately following the death, um, and also that response to the stress that's related to a death. During the period of acute grief, sometimes you find people become or the caregiver or sometimes family in other situations, they become confused or not even certain about their identity. Uh, they disengage sometimes from those usual activities and may even experience disbelief or shock that their um, loved one is actually gone. The normal grief, that's considered usual feelings or behaviors or reactions to a loss. Normal grief to a loss can be physical, it can be emotional, it can be cognitive or even behavioral, cultural. Um, Active grieving can sometimes take years because no one gets over the loss, but the relationship with the deceased typically changes. Um, and there's usually the reconnection at some point to the world of the living. And again, I just want to, as I about halfway through expressing the types of grief, I do just want to make sure that we remember that we as professionals deal with grief ourselves in our own way. Can't say that enough. Complicated grief, of course, that's seen in about 10 to 20% of those that have had losses. Um, Typically is higher when a parent loses a child or so it's really important that we make sure that someone that's experienced some complicated grief actually gets the assistance that they need because there are 4 types of that grief, the complicated grief, and that is chronic, which is just normal grief reactions that never go away or they just continue for very, very long periods of time. That's also can be considered as the DSM-4, the prolonged grief disorder, and it's been added to that DSM. Delayed grief, that's kind of characterized by those normal grief reactions that are suppressed. And sometimes they even get put off. The survivor, whether it's consciously or unconsciously, they just avoid the pain of a loss, or they refuse to talk to anybody about their grief, or they're not interested in bereavement groups or and such. Exaggerated grief, that's another, that's really intense grief. It's that reaction that may have, nightmares or delinquent behaviors or different phobias or thoughts of suicide. That's really can really become difficult. Masked grief, that's considered where the survivor is not even aware that the behaviors interfere with their normal day-to-day functioning. You find in mass grief where the the um the bereaved typically does things like maybe cancel lunch, doesn't want to go out, wants to go to the cemetery, maybe sit by the grave, or just spends those times where they just cut off regular life and just kind of flow in that idea of being just wanting to be near their death, their deceased. The fifth and final type of grief is disenfranchised grief. And it's defined as a loss that's not validated or even recognized. Sometimes society may not want to acknowledge the grief and doesn't know how to deal with that particular type of loss. Those that are affected in this way, they don't feel the freedom to really acknowledge their grief or their pain. Some of the folks that are at risk for disenfranchised grief would include partners that have end-stage HIV, some ex-spouses or ex-partners or fiance, mistresses, lovers, workers, children, women that have experienced a terminated pregnancy or stillbirth. So just keep in mind that there is a direct correlation to disenfranchised grief as to who typically, and oftentimes, those that are in corrections can be considered a disenfranchised group of folks.
Yeah.
I'm sorry.
Yeah, I was going to say
Yeah,
that there may be high on that list of disenfranchised grief. Folks not recognizing that even the incarcerated can experience grief.
absolutely.
One of the things we hear so often is that they don't deserve that opportunity
Mm-hmm.
to express grief or to feel grief.
And
When
to that,
when you see people only as quote animals, that but we now realize that even animals experience grief, even the animals. So
that's exactly right. And I think that I think that it could be misconstrued in the fact of saying that, you hear that they don't deserve that. But, honestly, to be able to feel what we feel, it's a basic human right for everybody. Everybody should be allowed to feel how they feel. So when we think about, when we move on and start thinking about that whole grief assessment, of course, that includes that begins at the time that the patient begins to get sick, or we know that they have long-term illness. That assessment continuously ongoes throughout the course of the illness. The assessment and reassessment is done, should be done frequently during even the bereavement time, just to alert the staff to possible signs and symptoms or reactions to complicated grief from your volunteers even. Of course, it's important to be honest in all aspects of care, that diagnosis and of course the goals, and of course I don't really know. I'd like to see if someone from corrections can kind of speak to me, or have experienced, or could kind of speak to the whole idea of that process of the conversations between the professional and the patient as their health declines. Does anyone have an experience to something that you could share today with the group? No? Okay. I'll move on. Maybe someone will have a comment in.
maybe rephrase that. What you're looking
Okay.
for? Because I think everybody, well, probably on this call has been around folks inside of corrections who are actually going through the process of dying, whether you have hospice or not to support.
Mhm.
I mean, and you're asking if anyone has already had that experience of
I
suffering
just,
inside of suffering from a terminal disease inside of corrections.
well,
Is
it
that what?
wasn't necessarily, no, not necessarily that, just if they
Mhm.
had an experience, a particular experience that they just wanted to share, like where a patient was really forthcoming, or, you know, fully understood, or maybe didn't understand at all, or, you know, maybe had questions as to, I don't know why this is happening. You know, we see it all the time on this side. So I was just curious to see if someone had experienced it from within corrections. Sorry if I made it kind of vague. I apologize for that.
Okay, I had a student who got diagnosed with cancer, and she ended up having to go into a clinic room, and we had long conversations about that, about what is it, why her, why now, what does that look like?
Uh-huh.
Conversations with volunteers coming in as well, sitting with her other students. And it was a different setting for me than in a hospital setting or with parishioners church, because just the conversation was more limited in scope, in one sense, but not in the other.
Right, right. Wow. And of course, I guess you could see even here, looking at some of the interventions, of course, you provided presence and were able to listen, just being able to provide support, um, be able to normalize and individualize that process as best you possibly can. And of course, even allow actualization, the loss, and even facilitate living, you know, or even being able to go forward um, in serious illness, or to be in a position of dying. So thank you, Beth. I appreciate that. Anyone else? Okay. So thinking about grief support, I know that we talked about it a little bit earlier about being able to provide support. Of course, we talked about that online, or that opportunity for um, inmates to be able to support each other. Of course, these are other ways that group support, community support, even book therapy, and even individual counseling. And also one thing to keep in mind as it relates to the multiple cultures that I'm sure that you guys experience within corrections, just those rituals as it relates to be able to deal with their grief, or how they deal with what they're dealing with, I guess, for lack of a better way of putting that. Of course, the whole idea of grief work, it's never, ever completely finished. That healing, of course, happens when the pain gets a little bit less. Grief doesn't grow smaller, but Lois Tompkins says, but we grow around the grief. So that allows us to be able to better cope, I guess, for lack of a better way of putting that. I mentioned earlier about Mrs. Sapanio, Dr. Sapanio, who provided some information at the start of this course that we had. She was from Utah, I believe. She actually she co-authored and wrote an article, and this is a link to it. And I just wanted to just share with you. It's the grief experience of the prison inmate hospice volunteer caregivers. And basically, just in a summation, it explores that emotional and psychological impact of those volunteers that provide care. It looks at how those individuals navigate their grief as they care for the dying inmates. It also highlights the unique challenges that they face being within the prison system. And she said that the study was actually put into place. Of course, they use Angola as the model for this research. And she said that the study was put into place to help deepen that understanding of bereavement needs among inmates, those caregivers, and how they maintain their commitment to providing compassionate end-of-life care. Very, very interesting article. He said that some of the key findings from this study was that caregivers that are inmates actually have profound grief, but they lack the support systems to help them cope. She also found that in spite of the emotional burden, volunteers remain committed to being caregivers. They have a level of commitment to provide care regardless to the burden that they feel. And even I think I even saw it quoted where they said that they don't even have time to come up for air sometimes between deaths and between caring for, because of course, from a volunteer inmate that provides hospice care, that's in addition to everything else that they have going on. It's not a paid position, and it's just they rotate. It's interesting to see, but they rotate their care in addition to any of the other chores or things that they have. And of course, this study also kind of highlights the need for the structured grief support within those hospice programs that we chatted about. And also the report that those inmates said that hospice gives them a sense of purpose and a sense of personal transformation. So again, this is a link to that article. Very interesting. You guys may find it quite resourceful. Oh, I think I went backwards. Sorry about that. Hang on. Cumulative loss. Just thinking about the idea of loss after loss after loss. Basically, what it does is it just begins to grow and grow. We, from a standpoint of being professionals, have to be able to allow ourselves an opportunity to feel what we feel from a professional standpoint, and not to allow moral distress. Of course, moral distress comes to the point where we feel like, it's futile. What we do, we become so fatigued to where compassion fatigue kind of takes place, where, there's just there's not much breathing room between all that we see is death. And then we just start to question our own existence and why we do what we do. So there's a lot of things that can actually happen that we can allow as professionals if we're not cognizant of our own the idea of loss. And I heard someone say, I've heard it said before that, the way that you deal with death is the fact that knowing that everyone lives and everyone is going to die, but you have to compartmentalize that death in order to care for those that are still living. So it's kind of like, it can be very complex, but I just want to make sure that being able to take care of yourself and realizing what your stand is or your stance is on being able to provide care can kind of get to the point to where, as we in the helping profession have to be able to utilize a lot of energy taking care of patients and situations, is constantly stressful. Those end of life scenarios can be, we see a lot of suffering, a lot of psychological pain, and a lot of moral distress. We just have to make sure that we don't become attached to that, which could lead to this next section that I'm going to just chat about. And that's that as professionals, we're at risk for moral injury, moral distress, and compassion fatigue. Of course, these can lead to burnout. And we need to understand the differences between these in order to guide assessment and even some interventions. So when I think about moral injury, that's that psychological distress, the behavioral, and even social. Sometimes it can be a spiritual aftermath to traumatic events. It can occur in response to acting or even witnessing behaviors that go against our values and our own moral beliefs. Feelings like guilt, shame, disgust, anger, those are some of the reactions to moral injury. Moral distress, that kind of happens when we know ethically what's correct, but powerless sometimes to actually take that action. Of course, that happens when, for instance, we know the right thing to do, but because of institutional constraints or policies and procedures, kind of make it impossible to pursue this course of action. Compassion fatigue, that's kind of becomes a syndrome that results from that constant exposure, from the stress of, working with individuals that have, that are sick, and constant health issues, as well as death and dying and suffering. It can lead a person to become, actually, believe it or not, unable to love, to nurture, to even care for, or even empathize with suffering. It can also impact personal relationships with our family, our children, our spouses, and friends. Then, of course, the big spiral out becomes burnout. And that's that broad-based syndrome where gradually over time, we interact within conditions, those pressures, stressors of the workplace or the environment in which we are. This burnout typically is associated with a situation, not necessarily a person. It manifests itself either physically, psychologically, even. We lose motivation. Emotionally, we become totally fatigued and exhausted, become cynical, and even ineffective from a professional standpoint. Some of the factors that we can associate with being or becoming burnout from a societal and cultural aspect, that includes the politicization of science and the HEAL, structural racism, health inequities, misinformation about health, that unrealistic expectation of those healthcare workers from the healthcare, excuse me, from the healthcare system, that paperwork and the technologies, or I'll say the lack of technology sometimes, care coordination that doesn't always come together, even some misaligned regulations, all can contribute to that healthcare worker burnout. From an organizational standpoint, lack of leadership, excess in our workloads, and that disconnect between values and decisions, these all contribute to that organizational burnout. From a standpoint of a workplace and learning environment, being able to not have the flexibility that we need, or the autonomy or voice, these all contribute to us feeling, or a person that can become actually feeling powerless in the workplace. A lack of culture of collaboration, or even limited time with patients and colleagues, that kind of adds to that negative work environment. Not paying attention or not feeling like our well-being as healthcare workers is really being paid attention to can also kind of lead to and add to becoming a kind of a toxic workplace. I'd be remiss if I start talking about burnout if I didn't just even make mention to the idea of bullying. And of course, pretty much everyone has kind of witnessed some type of bullying. Can take many forms: experiencing behavior unwelcome, offensive, and unsolicited, or even objectionable. Of course, that all leads to a poor work environment, big staff turnover, lower patient satisfaction, and poor outcomes. So the idea, of course, is to become self-aware, be proactive, and take care of ourselves. Being able to do that, of course, is examining those expectations that we have for our positive outcomes, past failures as well as past successes, just being able to reflect on those. Self-efficacy, knowledge that I am capable, being able to recognize that yourself, that you are capable to do a job that you've been provided with. Body monitoring, as well as providing and having their own individualized wellness plan. And of course, wellness goes beyond physical, guys. I'm talking about the whole psychological, even social wellness plan. These are things that we have to do to be able to take care of ourselves. Emotional labor, that comes with energy and resources, not taking time to rest. It's increase on stress, emotion, exhaustion, being cynical, inefficient. I talked about that. But when we have balance in our life, we have self-efficiency, we're optimistic, hardy, and even resilient. Because remember, being able to provide hospice or palliative care can be emotionally taxing. And it's really hard to establish goals if we're in balance within ourselves. Being able to adapt.
One of
Yes.
the things that goes hand in hand with that, establishing boundaries.
Absolutely.
And people have, especially people that are not experienced with it, have a very difficult time in setting those boundaries. And there are times we have to know how to say no.
Right. And you know, I found from personal experience, Don, that was one of my biggest life lessons. And that was being able to say no when it had the potential to have a detrimental effect over me as a professional.
Mhm. I
So
know
you,
I know many nurses that I have met, many chaplains that I have met,
mhm,
um, social workers have a very difficult time with establishing and maintaining boundaries.
mhm. It's exactly right. I've even heard it said that healthcare professionals have been told to control their emotions and distance themselves from their patients and their families. Well, when you think about patients that have serious illnesses, of course, they require some intense professional involvement and some compassionate care. So how do you distance yourself and yet provide this care? So it becomes a balance. It becomes a juggling act, being able to take care of yourself as you take care of other people. Um, I've also seen very cold, for lack of a better way of putting it, emotional caregivers that can go through the motions of providing care without lending anything from their heart, for lack of better way of putting it. And so the care comes off as being cold and selfish. So it's again, I can't elaborate enough on how it's such a balance, and it's a daily balance, and it's a daily check and balance of ourself, because you can't give until you're completely depleted and you have nothing else to give. That's not fair to us as professionals to be able to provide care, and we give until we've given out and have nothing else to give. So again, that can be a catch-22, but I think that as we go and as we grow professionally, these are things that ongoing that we learn, including going back to what Don said, even those barriers and the boundaries that we have to be able to put in place. Anyone else have anything else to add to that? Okay.
I would just add that when a person gets to that point that they are practicing, they're going through the practice, they're going through the motions, and it's cold and they're not tied to it mentally and emotionally.
Mm-hmm.
Patients pick up on that in a hurry. You may not think they do, but they pick it up very quickly if you're just going through the motions.
That's exactly right. And it can oftentimes be the start of the snowball effect of a negative patient experience.
Exactly.
You even have patients that act out as a result of them picking up on that coldness or that lack of compassion. So you are exactly right. Um, it's almost like even when you work with children, children know when people don't like children and that are working with them. Kind of such as the same, it's kind of like the same phenomenon, that going through the motions, that can be, it's like a radar. They pick up on it very quickly. From a standpoint of the personal well-being that I was chatting about, of course, that's different for each and every one of us. We just have to be able to establish our own balance within ourselves, that holistic, that whole from head to toe care, from a physical, emotional, and even spiritual standpoint. And I'll even go as far as to say from a professional standpoint as well, because we all have code of ethics that we should be following. Um, and we all, if you haven't, just keep living, and you will come across some ethical dilemmas, or times when you know what to do, but there are things that keep us from doing what we know is right to do. Those ethical dilemmas. And of course, role model good self-care, not only for yourself, but for those that we work with. Just being able to take care of ourselves is kind of contagious, if that makes sense. Did anyone have any other questions or comments that you wanted to provide? I actually did. I will share with you. There were a couple of sections of this PowerPoint presentation that kind of made it a little shorter, and that was just dealing with age development and children, because of course I tried to cater as much as I could this to the population that you guys serve. But I will share with you that As I mentioned before, in the resource packets, there are a couple of videos. Like I said, also there's that article that that was written by Dr. Piano that is really phenomenal whenever she actually took the research from Angola and actually interviewed with some volunteers and kind of talked about their relationship with death and dying and their ability to continue to go on and provide care. And I think I only have one more slide. Let me see here. Yep. End of care life. Of course, I've said this several times today. It just doesn't end with the patients dying. We all have to recognize and respond to our own grief patterns. Bereavement care, of course, is interprofessional from a standpoint of, everyone has to allow and provide their own unique expertise to the idea of dealing with death and dying. Even though you guys may not have had a individual or personal relationships with the patients that you care for, it is a human being and it is a human life, and loss of life for whatever reason impacts us sometimes more than we actually realize. So just take an opportunity to realize that grief, loss, and then grief, and then even bereavement, and that is living after the death of an individual. It doesn't necessarily have to be a family member, can have its toll. So we have to weigh and measure our own emotions, our own thoughts, and our own feelings as a person, but then also as a professional. Realize what gets us up in the morning, what keeps us getting up and going to do the same job that we do day after day. Have to be able to identify that purpose and have the meaning behind what we actually do and the services that you guys provide. I'll stop sharing right there because that actually takes care of the PowerPoint presentation. So I find that we actually have a little extra time today, maybe hopefully to be able to find some discussion today around, if not today's session, just some of the sessions that we've had so far as it relates to the whole entire palliative care and hospice, and even we've dealt with ethics and communication, we've dealt with grief, we've dealt with loss. Is there anything that anyone would like to add or any comments?
I would like to say one thing. We have started a support group for bereavement managers, folks that are managing hospice programs, bereavement programs. When we have in fact, this coming Thursday, from 2 to 3, they will have a Zoom call, and it's just emergency. I mean, it's just hospice bereavement managers. And if anybody inside of corrections would like to be part of, it's a quarterly Zoom call, just to support them in terms of thinking about how we're dealing with grief, how each hospice is dealing with grief, and the types of programs they're putting together. If anyone in corrections would like to be a part of that, just send me, actually send Marquetta your name, because she is sending out the calendar invite for that event.
Marquetta, one of the things that you touched on, and I would expand on it just a little bit. My background is, the majority of my nursing career falls into one of two areas, either critical care or hospice. And now, of course, kind of putting everything together in corrections. But just as in critical care, when you have that patient that codes, and you're spending so much energy and so much effort in that code process, as that adrenaline builds, there are very real physical manifestations that hit us. And once that code is over, as that adrenaline starts to bleed off, you have physical manifestations. You can actually feel sick about it. The same thing occurs in hospice as well. when you have that patient who is actively dying, that level of focus goes up. Your, your attention to them is heightened, and the same type of reaction can occur. You have that adrenaline buildup, and when that patient finally passes, as that adrenaline starts to bleed off, you're going to feel some of those same, and that's one of the things I think we need to communicate to our volunteers as well, that there can be a very real sense of loss of physical manifestation with that loss that is very understandable. It has a very real meaning. It's a very real consequence of being engaged with that individual through that process. Your body is going to manifest it. And those things are not, it's not weird. It's not something that is out of the ordinary. It's not abnormal. It is a normal reaction to the entire process.
Right.
So we need to communicate that to those people that we're working with, especially those who have not worked in hospice in the past,
Right.
or any critical care setting in the past.
Yeah.
Exactly.
And Don, the whole concept of that IDT is to support one another. And so people don't feel like they're doing this alone, and that they have the support of everyone on the team, whether you talk about the physician or security. That's vital.
As a director, one of the things that I would try to make sure that we did was, when we had a number of deaths between IDTs, is discuss those individuals, discuss the things that occurred, discuss the feelings that the different caregivers, and whether it's nurses, whether it's chaplains, whether it's social workers, whether it's volunteers, whoever it may be, and make sure that they are drawn in and they have the opportunity to express those feelings, express that sense of loss. What were the things that occurred that went well? What were the things that were funny? What were the things that were very sad about the whole process? And it helps you to refine your approach with the next family. One of the things that I always told my new nurses coming in, any new employees coming in, was these families may not know us from Adam, but they have extended to us the honor of helping them through a transition that they've never been through before. And we need to view that as such. And we're going to be taking that same position, or my goal is for us to take that same position with these inmates.
Yep.
We make this journey with, as they make that transition, they're entrusting us to help them make that transition the best that it can be for them. And, but that is an honor.
Yep.
And it is a privilege for us.
Yep.
And we need to view it as such.
Yep.
And treat them as such.
Right.
Sandra Tizer, is not on today's call. I was talking with Sandra too. She's the nurse manager now at Angola, and she was talking this last weekend. Sandra's not on, right?
Yeah.
Because she could tell the story much better. But last weekend they had a patient that went on to vigil, and the family showed up. And his family was inside the entire weekend while he passed away. And the volunteers who made that possible she was just going on and on. She said, without them, we could not, this would never have happened if we didn't have the volunteers to support that family through this, because, it was constant. And there was a hospice volunteer that was there the entire 48 hours that the family was there. They were constantly rotating. They do I think they do 6-hour shifts when they're on vigil or something like that. But she said it was the most amazing thing to watch, and to have that experience of being able to witness that. And she was really moved by it. I was like, oh, so in other words, we get to share in very special times in people's lives, whether they're the patients or whether they're the volunteers. This affects us. This impacts us, and it has an impact upon how we live, hopefully how we live our lives. So
Exactly. I think C. Smith has their hand up. Do you have a hand up? I see a hand raised on the screen. I was just making sure you didn't have a question.
let me see if there's anything in the chat box.
I think on the front end to add strength and to add fortitude to a hospice program in corrections, I would think it would be to allow the volunteers an opportunity to, and no matter what that looks like, to debrief. And that is between deaths, even if it's just debriefing with the social worker, or even if it's debriefing with the nurse, because it not only gives them strength, it gives them an opportunity to exhale and then to be supported by your staff. So I think to strengthen as it rolls out of the gate, to strengthen that program is going to be to allow, because I don't know that even in an IDT situation, if that would even be something the volunteers could even be a part of. But I think that just allowing them to have that time to debrief between deaths is going to be vital. And then, of course, hopefully you guys will pick up with also the grief support groups that has already been facilitated, so that they can amongst themselves hold each other up. But they also need that outer support of the professional staff that are staffing the hospice and palliative care programs. Was there something in the chat box, Jamie? Another question?
I don't see anything. No. Let's see.
Okay.
Let's see. I'm looking, but I don't see a hand raised.
Okay.
Does anybody, if you have a hand raised, please say something in the chat box, because I'm not seeing it right now.
Okay. Okay. I definitely didn't want to have someone with a question and not have an opportunity or a comment even to weigh in. I will say, of course, the final hours will be discussed in depth tomorrow, next week. And of course, any questions or any compilation of questions or suggestions or things that we could do to kind of continue to gear this, because it's the first of many. I'm in hopes of being able to provide education within corrections, starting at the professional level, and then being able to also provide education to you guys as volunteers in the program as well.
As members, you'll be hearing about all the educational opportunities that we offer to our members via Zoom or in person, as well as our annual conference. We have an annual leadership conference that's coming up at the end of July, as well as our annual bereavement conference. So you'll be part of all of that.
Yes. Also, Jamie, I think you may have already mentioned this before about the planning phases that we are in for our chaplaincy training. Have you mentioned that to them before, that we were looking at to model what we did a couple of years back? Oh.
We haven't sealed any deals yet. We're still waiting. So I don't want to mention that yet.
Okay, gotcha.
Not until we seal deals.
Gotcha. Okay. Well, I then have nothing further. If you guys don't, please know that you'll get your 1.5.
Any questions of Marquetta or Don or myself? Don, is there anything that you need to sort of broadcast about June 12th?
Um, just to let people know, the plan is and I'm going to be sending out some emails about this, but the plan is to probably gather. We're planning on leaving here probably around 3 in the afternoon on the 11th, staying in St. Francisville that night. For those of you with MDOC, please get with your supervisors, see how they're going to handle your travel and expenses, things like that. With Vital Core, if you're planning on spending the night, we've talked with Viola. The expectation is that we will pay for our expenses on the way down and back, and then we will turn them in for reimbursement once everything has been accomplished. But that is the plan. And as I find out from the folks at Angola, we may need to gather some information from you so that they can vet the people, and that's what I'm going to find out about is what information they need so that everybody can be vetted and we don't run into situations like they did in Newark, where you're trying to get into a facility
Yeah, no.
and nobody knows you're coming.
Yeah.
So we don't want that.
Right.
But
And
please
everybody should mark their
keep an eye.
calendar. June 12th is that date, correct?
June 12th is the date that we're going to be there. I will talk to Tanya and Sandra about what time they want us to be there that morning. We'll get all of that information out to you. And I had anticipated probably around 3 o'clock would have been when we'd finish up, and then everybody head back home from there. So that'll just give you an idea of something to kind of go on.
I know the visit I'm doing tomorrow is from 10 to about 3. I would imagine because of the depth of insight that they're going to be trying to give you all with they're trying to put wardens and security with security and doctors and nurses and nurses and all that kind of stuff. They're trying to group everybody with their like at Angola. So it may be a little earlier that we'll start rather than 10. Yeah.
I will say also on the MDOC side, it is very important that you begin that process. If you haven't already, I've asked you to, but if you haven't already, please start putting together the list of potential volunteers, because we're going to need to go through that. We need to kind of winnow it out, try to make sure that we get the people that are going to be most well adapted to be serving as hospice volunteers or patient care volunteers for our program. Yeah. So we want to find the people that I know I have talked to a couple of the superintendents about it already. And so please be thinking about that, be getting that list together so that we don't get to the last minute and we're ready to start training volunteers and we don't have the volunteers gathered yet. Please.
I know one of the things that when Angola launched theirs, one of the things that Warden Kane did was he went to the leaders of each of the different groups inside of Angola. You know, there are all sorts of groups. There's the American Legion, there's lifers, there's
we've got veterans,
exactly.
groups.
And he actually went to the leadership of each one of those groups, inviting them to consider, becoming that first group of hospice volunteers. And I think it sort of stunned everybody, and then all of a sudden it all started making sense because you want leadership doing this, whether it's administrative leadership or clinical leadership or incarcerated leadership. It's about finding leaders who can can come up with creative and innovative ways of caring for folks in their facility.
I know Dr. Masters has her group of field ministers who have done some outstanding things. I know at CMCF, where I've had personal work with them. Chaplain Rhodes at MSP. I know they've got a group of them up there. Start talking to those people, see what their interest is, or people that they know who might be interested and would fit into the group that we're trying to put together.
Anything else that needs to be said today? Okay. Next week, we start at 1:30, correct, Marquetta? It's a final hours. Marquetta, you with us?
Yes, 1:30.
It's a 1 hour session, all right, for our final
Yes.
hours. Okay.
Yes.
Yes. So next week we will
Yes.
start again at 1:30. I want to thank you all for your attention. We need you to put your name and your email address in the chat box now. And then within 24 hours, you should see an email from us directing you to the evaluation. You have to complete the evaluation. And when you complete that evaluation, when you complete it, then it gets stored in your profile. You'll be able to see that certificate, and you'll have another. And we want to thank the Franciscan missionaries for sponsoring your continuing education for this entire program. So thank you. Okay, so having said that, I look forward to seeing everybody next week, same time, same station. Take care.
Thank you all very much.
Thank you.